Hi friends, so now we are starting off with integrated rheumat system. Alright, so rheumatology is one of the most scoring systems that you have in medicine. So here not much of integration actually. We will be integrating pharmac, but there is no physio and path counterpart here. So mainly we'll be talking about medicine and a lot of it is from Harrison's. Alright, so this is one of the systems which I did do very diligently from Harrison's way back in my final prof, and I loved the way they have described it. This is one of the best systems in Harrison's in my opinion. But if you've not read it from Harrison's, I'm here for you. Okay, so that is what we're going to be doing now. Let's start off with autoantibodies. If you have no time and you have only one thing to do from rheumat, it's autoantibodies. All right, so you need to know each and every antibody and what it actually implies. And this is a list which I've compiled for you, actually 2 pages of list that I've compiled. All of these are the antibodies that we gotta know. So first is anti-nuclear antibody here, and this, remember, is the most sensitive for SLE, and now according to the recent update, this is now called as an entry criterion. This is known as the entry criterion, meaning this has to be present for us to make a diagnosis of SLE. Alright, so that is how important it is. It is the most sensitive. Then coming on to the specific ones, we have C1q and dsDNA. So here these, remember, correlate the best with activity. So they correlate with disease activity, and this is how we can actually know what are the active flares. Okay, so these are the 2 antibodies that we want to measure when we are suspecting active flares. C1q better than dsDNA for the correlation. Okay. Antihistone antibody, very, very important. It's for drug-induced lupus. From drug-induced lupus, you also want to remember the drugs which are actually gonna be causing lupus. So here we have the ship drugs, isn't it? So what are the ship drugs? We have sulfasalazine, we have hydralazine, we have isoniazid and procainamide. So these are the ship drugs. In fact, you can remember almost all of the sulfa drugs can actually be included in this list, alright. And also remember, these ship drugs are metabolized by acetylation, alright. So that's one more thing, acetylation and drug-induced lupus, where this list comes together. So this is antihistone. Then we have anti-Smith or anti-SM antibody, which is the most specific. So SM is not SN but SP. So this is the most specific antibody for SLE. Then we have antibodies correlating with different manifestations. So anti-neuronal or glutamate receptor 2 correlates with CNS. These correlate with findings of neurolupus or CNS lupus. So obviously they're not going to give you neuronal antibody because that's very obvious, but they can give you glutamate receptor. So remember, glutamate is correlating with neurological findings. Anti-ribosomal P correlates with P for psychiatric manifestations. So neuropsychiatric manifestations in SLE, the marker is anti-ribosomal P. Now I've kept ribosomal P and U1 RNP close together because that can get confusing. So remember, ribosomal P is psychiatric of SLE, but anti-U1 ribonucleoprotein is going to be denoting mixed connective tissue disorder. So this is for an overlap syndrome or a mixed connective tissue disorder where you have manifestations of SLE, RA, scleroderma coexisting. Okay. Then you have anti-Rho and La or SSA and SSB, which are both findings in Sjogren's syndrome. In addition, you want to remember Rho, a baby cries, or Rona as we say in Hindi. So Rho is with a child. So this is a marker of congenital heart block. Alright, so this increases the risk of congenital heart block or neonatal lupus. Okay, so this is very, very important. And if Rho and La are present in next, you want to remember anti-Jo1. So anti-Jo1, remember, is also known as anti-synthetase, and earlier this used to be a part of dermatomyositis, but now there's a new syndrome, anti-synthetase syndrome, where we use Jo1 as a marker. Anti-Mi2 is a marker of dermatomyositis. We shall be talking about this in detail. So this denotes a good prognosis actually. The presence of this autoantibody denotes a good prognosis in dermatomyositis. Then talking about scleroderma and crest. So whenever we have the bigger name, that is topoisomerase and SCL70, this is scleroderma or diffuse scleroderma. There is centromere because it is small and limited. It is also limited scleroderma or crest. Okay. So this is about the connective tissue disorder autoantibodies. For ANA, anti-nuclear antibody, what we do is this fluorescence pattern, and depending on the fluorescence pattern, we can further classify. This is slightly extra edge for INICT, okay. So wherever you see this homogeneous fluorescence, two antibodies show this. One is anti-double stranded DNA and second is anti-histone. Then you have a speckled pattern. So speckled pattern are your anti-Rho and La, which is SSA and SSB. From Rho and La only remember anti-Jo as well. So anti-Jo1, which was your anti-synthetase, and anti-U1 RNP, which is your mixed connective tissue disorder antibody. All of these show you a speckled pattern. And where you see this peripheral pattern, it is anti-Smith. So Smith was specific people are usually put in the periphery, is how you can remember. So this is peripheral. And nuclear pattern, this is seen in the scleroderma antibody. So anti-topoisomerase or SCL70. We might have one more pattern wherein you have centromere, so that is much obvious. This is seen in crest. Okay, so these are the different patterns: homogeneous, speckled, peripheral and nucleolar, that you want to remember slightly extra. This has not been asked so far. Talking about other antibodies throughout path and medicine that we need to remember. So TPO, I am sure you know, this is thyroiditis. It correlates with the activity of thyroiditis as well. Also, just to remind you, we've done this in surgery. If I do a radioiodine uptake scan, it's going to show me very low uptake in thyroid in thyroiditis. LATS is seen in Graves. So these are your long-acting thyroid stimulator. These are your TSH receptor antibodies which auto-activate the TSH receptors. And Graves, as you know, on radio uptake iodine study are gonna show you diffusely increased uptake. It looks as if the thyroid is angry. Okay, so this is Graves for you. Very important, anti-SM and LKM1. These are both antibodies in autoimmune hepatitis. This is something in path you want to remember two properties here. This is one of the areas where vowels stick together again. So autoimmune hepatitis show you two phenomena. One is known as enteropoiesis, wherein you have one cell eating up the other cell. This is a repeat INICT question. And the other is interface hepatitis. Alright, so all of the vowels sticking together, remember this, A-I-E-I. Okay. Anti-mitochondrial antibody. If you have to remember one out of this entire list, you tell me, ma'am, I have very limited memory, only one will fit. You choose anti-mitochondrial antibody. This is primary biliary cirrhosis. Alright, so PBC, primary biliary cirrhosis, you would be given a young female with pruritus, with xanthelasmas can be given. Alright, so you have pruritus, you have xanthelasmas that could be present, you have osteopenia which could be present. Alright, so this is primary biliary cirrhosis, and here the histopathological marker is also very important. Remember, on histopath we have florid duct lesions. This is to be contrasted with primary sclerosing cholangitis, which is gonna show you onion skinning duct lesion. Alright, so onion skin fibrosis around the bile ducts would be seen here. So remember, AMA is something which is very important for primary biliary cirrhosis. Coming to ANCA, we are going to be talking about this in vasculitis. So we have P-ANCA and C-ANCA. P-ANCA is positive in microscopic polyangiitis and Church-Strauss syndrome, which is now known as eosinophilic granulomatosis with polyangiitis, whereas C-ANCA is in Wegener's granulomatosis. So how to remember is, instead of writing W like this, write it like this, and that is C. Alright, because I've seen a lot of students confusing C-ANCA and P-ANCA. So C is W, Wegener's granulomatosis, which is now known as granulomatosis with polyangiitis. Okay, then we have ASCA, which is positive in Crohn's disease. Remember atypical P ANCA in ulcerative colitis, whereas Crohn's disease shows you anti-Saccharomyces cerevisiae, that is ASCA. So, Sir and Sir with Crohn's disease. Alright. Then we have rheumatoid factor, which is the most sensitive in rheumatoid arthritis. So they ask you what is the rheumatoid factor. So you want to remember this is IgM against the FC of IgG. So how to remember this is MRF. You know MRF tires. So you want to remember IgM is rheumatoid factor. Alright. So this is about all of the autoantibodies in one place. Now we start off with one connective tissue disorder after the other. So the first is SLE. I'm sure it's about you. First is SLE, very important. If you've ever seen House MD in your life, you would hear this phrase in every single episode, right? That's one of the differentials all the time because of the multiple manifestations that it can show. Before I go into the images, I want to talk about the recent update in the ACR-EULAR criteria for SLE. So as I said, ANA more than 1:80 is an entry criterion. This is a must in every patient. This is the most sensitive autoantibody that you have in SLE. Then out of all of these features, you should have more than or equal to 10 points for the diagnosis of SLE. So what are the features? Fever, very non-specific. In the cutaneous domain, what could be there? There could be alopecia, that is non-scarring, oral ulcers, subacute cutaneous or discoid lupus or acute cutaneous lupus. These are the cutaneous manifestations. Synovitis, very important. Remember that comes under the arthritis domain, but it's actually synovitis which is the finding. Neurologically, there could be delirium, psychosis or seizures. Serositis wise, there is pericardial pleural effusion. Hematologic, very important, leukopenia, thrombocytopenia and autoimmune hemolysis. So it is actually hemolytic anemia which is the most common form. This is a repeat question. You can also have anemia of chronic disease, but that is not a part of diagnostic criteria. Very important, renal domain. You have various gradings. You have actually 6 types of lupus nephritis, out of which 3 and 4. Can you see? This is the only feature which directly gives you a diagnosis, 10 points in one symptom. So 3 and 4 lupus nephritis are the ones which actually require treatment. They are indication that you have to give treatment. So that is the most important. Type 4 is the most common lupus nephritis. So let's just finish off lupus nephritis. The most important feature here in immunofluorescence in lupus nephritis is what is known as the full house effect. This is the only disease which is going to show you deposition of all of these IgG, IgM, IgA, C3 and C1q. So this is what is known as a full house effect in lupus nephritis. Remember that it's the type 4 which is the most common type. Alright, and this is the diffuse nephritis. This type is known as diffuse nephritis. Fine. Going back now from the renal domain into the immunological domain. So here what you want is either the antiphospholipid which constitutes your APLA also. This we have done in gyne-obs already. So you have anticardiolipin, anti-beta 2 glycoprotein or lupus anticoagulant. These 3 need to be on your tips. These are the 3 markers of APLA. Or you have low complement, or you have dsDNA or SM, which are your specific antibodies which give you 6 points each. Alright, so this is about the classification. So in a nutshell, we have clinical and immunological domains which need to be positive. So here we have APLA, complement and the antibodies. Here you have fever, cutaneous, synovitis, delirium, serositis, hematologic and renal. So you need not memorize this entire list, just go through the manifestations once. What you can get questions from are the images. So this, as you know, is the malar typical rash of SLE. We have done this in dermat as well. So there is this pairing of the nasolabial fold versus a rosacea wherein this pairing is not there. When you see this annular lesion, this is how discoid lupus looks like, and what you are seeing here is actually arthritis with more dominant synovitis. So what you're gonna see here is the typical Jacob's arthropathy. Jacquard's arthropathy meaning that there are no erosions, but there are deformities like RA. So this is known as a deforming non-erosive arthropathy. So you can see the typical deformities but no erosions on the X-ray. So this is known as the typical Jacquard's arthropathy of SLE. So these are the salient features from SLE. Going on to sarcoidosis, very important, respi rheumat overlap. This always gets asked. So here on the X-ray, typical finding would be 1, 2 and 3. 3 groups of lymph nodes. So 1, 2, 3 sign, also known as Garland sign here, also known as a lambda sign on the gallium scan. So this is where you have bilateral hilar and right paratracheal group of lymph nodes which are enlarged. In addition, you can have pulmonary infiltration findings as well, but hilar lymph nodes are the hallmark. What you see on the shin are these tender lesions which are erythema nodosum. So what they ask you are 2 named sub-syndromes of sarcoidosis. So one is Lofgren. So Lofgren is hilar lymph nodes with erythema nodosum. The name itself tells you there is EN, whereas Hereford is fever. So this is fever with 7th cranial nerve palsy, which is the most common cranial nerve to be affected in sarcoidosis. Okay, so these 2 syndromes, do keep them in mind. So erythema nodosum, remember, is the most common cutaneous finding of sarcoid, but most common chronic cutaneous finding of sarcoidosis is lupus pernio. So this can also come as an image-based question. These lupus pernio are these erythematous lesions on the face that you want to remember. Histopathologically, what you see are these bodies, these calcification bodies within these giant cells and these granulomas. So we see non-caseating granulomas in sarcoidosis. We see these non-caseating granulomas in sarcoidosis, and these concretions that you are seeing are known as Schaumann bodies or asteroid bodies. Alright, so from sarcoidosis itself, S and A, you want to remember Schaumann, asteroid and non-caseating granulomas. On a gallium scan, you can have uptake on the parotid and the lacrimal glands, giving rise to this panda sign. Okay, so here you're going to be given a history of a young female who has fever, cough. On the X-ray, they can show you the hilar lymph node enlargement. So on the basis of this, you can have a lot of differentials. The most important is going to be tuberculosis, right? But what will clinch your diagnosis are these lab features which will be given to you in the question. So if they mention that the AS values are raised, that's a clincher, that's sarcoid for you. Okay, apart from that, because of these granulomas, what they have is 1-alpha hydroxylase. So this 1-alpha hydroxylase will result in active vitamin D, which can result in hypercalcemia. So there's hypercalcemia or hypercalciuria which is noted. Now very important, in the blood there is lymphopenia, but if you do BAL analysis, you're gonna have CD4 is to CD8, which is raised to around 5 is to 1. Normally it is 2 is to 1. Here you're gonna have raised CD4 to CD8 lymphocytes. You're gonna have lymphocytosis in BAL, but in the blood there is lymphopenia. Just for historical importance or reference, we had the Queen's test for sarcoidosis. Okay, so this is all you got to know about sarcoid. Apart from this, you also want to remember that on the X-ray, we have a grading system which is known as the scadding grading system, in which you have 4 different subtypes depending on hilar lymph node or lung manifestations. Don't really need to memorize that, just be aware that there is such a staging system. Okay, so this is all you have to know about sarcoid. Coming to scleroderma and crest. So diffuse disease is scleroderma, whereas limited is crest. So looking at all of the manifestations here, so this is an image from Harrison's which very beautifully describes all manifestations. So there's a color coding here. The ones in red are more common in the diffuse type, whereas the ones in blue are more common in the limited type or the crest type. Okay, so first of all, once you know what is the meaning of crest, few of the manifestations become very clear, right? So C is for calcinosis cutis. wherein you are gonna have cutaneous calcification, subcutaneous calcification. R is for Raynaud's phenomenon, which can give rise to digital ischemic ulcers. So remember Raynaud's, the color is also very important. So first you will have white followed by blue followed by red. This has also been asked, alright. So white is because of vasoconstriction. After vasoconstriction, because of cyanosis, you are gonna have bluish coloration followed by red when it becomes followed by red when it becomes dilated. Alright, so this sequence, Weber is what you can remember. From rubber you can remember Weber, white, blue and red. Alright, so this is Raynaud's for you. So C and R. E is esophageal dysmotility. So let's see GI. You have esophageal dysmotility that can give rise to GERD or Barrett's esophagus. And from S you have sclerodactyly. So this is an image that is showing sclerodactyly, that is sclerosis of the fingers. They become sausage-like. And T for telangiectasias. So this is what you are seeing as the nail bed telangiectasias. Alright, so this is again very, very important. And also one more finding which could be a potential question is this nail fold capillaroscopy. That is a technique that is done for this disease. So this is something that you will only see in scleroderma, where we are looking at the pattern of the capillaries at the nail fold to see the disease activity. What you are seeing here is calcification. So this is calcinosis cutis. This is sclerodactyly, and radiological finding, you will see the destruction of the distal phalanges known as acro-osteolysis. Okay, so these are all of the images that could be asked with scleroderma. So let's go through the manifestations one more time. Remember, in crest you have higher telangiectasias, GERD Barrett's, calcinosis, Raynaud's and PAH. PAH is more common in limited. Very, very important. Whereas in diffuse scleroderma, you have ILD, which is more common. You have cardiac manifestations in the form of cardiomyopathy and diastolic dysfunction, which is more common. Renal crises, very, very important. Scleroderma, renal crises giving rise to onion skin appearance of the kidneys or a flea-beaten kidney on a gross specimen. This is very important in diffuse, and joint contractures, myositis is also more common in diffuse type. Alright, so this is about scleroderma and crest. We already know the antibodies. Here in the diffuse type, you have topo1 or SCL70, whereas in crest, you have limited centromere like a crest. Okay, so this is about scleroderma. Next, talking about Sjogren's syndrome. So Sjogren's, as of now, I'm sure you know keratoconjunctivitis sicca, meaning dry eyes, dry mouth, everything dry. Alright, so dry eyes, dry mouth are the glandular manifestations along with parotid gland enlargement. So this is very important. Here I've also enlisted the treatment, but that's not very important. What we want to focus on are the manifestations. So dry eyes, you want to see by the help of this Schirmer's test. So they can give you this image-based question. There's a tear film that you're trying to measure, or we can do a staining in the form of rose Bengal. So rose Bengal stain or Schirmer's test is what is done here. Along with that, we'll have parotid gland enlargement. This is very important. We want to follow up the patient because you want to rule out lymphoma. There is high risk of lymphoma, which is MOLT, marginal zone lymphoma in Sjogren's. Alright, extraglandular, most common manifestation is arthritis. You can also have Raynaud's here. Very important, Sjogren 1. This is gonna be a cause of RTA type 1. There could be vasculitis and lymphoma. As I said, if it's diagnosed, you will have to do a CHOP-R regimen. Okay, so remember two significant things, RTA type 1 and arthralgia is most common. Okay, now anytime you have any glandular enlargement, bilateral parotid gland enlargement, there are three differentials that you want to rule out. Very important table. This is again from Harrison's. So one is HIV, Sjogren's, sarcoidosis. Presence of anti-Rho, anti-La favors a diagnosis of Sjogren's. If you have lymphoid infiltrate, very important, CD8 infiltration HIV, CD4 is Sjogren's, whereas granulomas will be seen in sarcoidosis. HIV related with DR5, DR3 and DR52 for Sjogren's, not very important. Obviously, HIV is going to be positive in HIV. Alright, so two most important things you want to send is HIV and anti-rolla. If you do a biopsy, CD8 and CD4 and granulomas would be the hallmark. Alright, so very important approach here. Now talking about IgG4, this is one of my favorite diseases for some reason. So IgG4 related disease is a group of lymphosclerosing infiltrative disorders. So throughout the body, different organs are going to have fibrosis and inflammation which mimics tumors. So you will see a bunch of growths and you will feel that a person has a lot of tumors, but no, it is actually an inflammatory condition. So the hallmark, that is the most common organ which is involved in IgG4 is pancreas. This is autoimmune pancreatitis, wherein the pancreas loses all of its lobulations and gives you this sausage shaped appearance. So you want to remember, most common manifestation is autoimmune pancreatitis. Pancreas appears sausage shaped, and this is the only reversible type of pancreatitis. Alright, so the only reversible type of pancreatitis is autoimmune pancreatitis. Histopathologically, there is a triad that you want to remember. So one, you're gonna have lymphoplasmacytic infiltration. So you're gonna have plasma cells and lymphocytes like you can see. Secondly, you're going to have fibrosis in the form of this very basket weave sort of pattern known as storiform fibrosis. So storiform fibrosis meaning basket weave fibrosis. And third is obliterative phlebitis. You're going to have inflammation of the vessels. So this is the pathological hallmark of IgG4. So there is a Mayo Clinic criteria which includes HISOT. So the short form is HISOT. There is characteristic histology. There is characteristic imaging like we have just seen. Third is serology. So we can measure the levels of IgG4. They would be more than 135. 4 is other organ involvement. So other organs would be biliary strictures, there could be retroperitoneal fibrosis, thyroid, salivary glands or vital pseudotumors could be there. And fifth most important is response to steroids. So this has such a magnificent response to steroids. I have never used the word magnificent for any response, but this is how dramatic it is. In 48 hours or lesser, you would see these tumors literally melting. So that's how I said this is the only reversible form of pancreatitis. Alright, so this is IgG4 related disease for you. Questions have not come from this, but I sincerely hope they do. So with this, we come to an end of connective tissue disorders. Now we go on to myopathies. So this is a very interesting approach to myopathies and is going to be very helpful to you in reaching to a diagnosis, not just in the exam, but generally if you become a practitioner as well. Alright, so anytime you have large girdle pain, which is shoulder and hip girdle pain in an elderly patient with morning stiffness and raised ESR-CRP. So ESR is raised but CK is normal. Always consider polymyalgia rheumatica. So this is PMR, polymyalgia rheumatica. Okay, so large girdle, elderly patient, frequently related to giant cell arthritis. If you find both of them to be raised with proximal pain, you must always rule out inflammatory myopathies that we are going to be discussing in detail. If you have both normal with a history of drug intake, so next to our drug intake history, if both are normal and you have proximal weakness but the pain is not much, you have proximal weakness but the pain is not much, consider steroid induced myopathy. Alright, so steroids lead to myopathy. On the other hand, if CK comes out to be raised with a lot of pain, then you must consider statin induced myopathy. So I hope you remember from biochemistry that statins block HMG-CoA reductase. Now when they are blocking HMG-CoA reductase, the whole cholesterol pathway gets blocked by statins, but there is also coenzyme Q, which is a part of the electrons transport chain, that also gets blocked, and that is why you have myopathy, and that is why statins should always be supplemented with coenzyme Q. Remember that. Okay, so here CK is going to be raised, and finally one where you have CK which is raised, but the hallmark is going to be delayed reflexes, deep tendon reflexes delayed, buzzword. You want to rule out hypothyroidism. Alright, so this is a very, very useful approach to all proximal myopathies. You know, in your clinics also you would see cases with proximal myopathies. You must rule out each one of them. So in your panel you have to include ESR and CK, and that will help you in the differentials. Okay, so PMR, inflammatory, steroid, statin, hypothyroid. Now let's go to inflammatory myopathies. So here I am sure you knew 3 coming into this, which was dermatomyositis, polymyositis, and inclusion body myositis. I'm going to teach you 2 more new entities. So this is from Harrison's. This is immune mediated necrotizing myositis, and the new syndrome is anti-synthetase syndrome. Alright, so not much you want to know except for the name here that you're going to be saying necrosis, whereas anti-synthetase I will describe to you in detail. Now remember, everywhere it's proximal, young adults, elevated CK, but inclusion body is an exception where you will have distal muscles also getting involved. You will have elderly patients with a normal CK. Alright, now coming to the biopsy. So all P's are going to be there in dermatomyositis. So perimysial and perivascular inflammation. So now you want to see this diagram. So what you can see is the peripheral cells are the ones which are undergoing atrophy. Can you see this? They're becoming smaller. So this is perivascular atrophy, and you'll see the inflammation in the periphery and around the vessels. So perimysial, perivascular inflammation. But if you see inflammation everywhere, endomysial and perivascular with CD8, that is polymyositis. Alright, so this on the basis of the images you can understand this is endomysial, whereas this is perimysial with perivascular atrophy. This is the hallmark of dermatomyositis. Necrotizing is obviously necrosis. Here also you will see findings such as dermatomyositis along with some necrosis, and inclusion body obviously is going to get inclusion bodies, and you're going to have CD8 here as well. Alright, so this in a nutshell is inflammatory myopathies. This is again INI-CT stuff. For other exams, what you want to remember are these 4 images. Very, very important. Lots of times NEET has given you questions here. This we've done in Dermat as well. So what you see is heliotrope rash. So this is the violaceous rash over the eyelids with edema. Heliotrope rash on the knuckles. What you are seeing are known as the Gottron papules, and this is a repeat question wherein they have asked you hallmark of juvenile dermatomyositis. It is Gottron papules. What you see around the nail bed are the nail bed telangiectasias, and what you are seeing around the shoulder is known as the shawl sign. As I said, a new syndrome has stemmed out from dermatomyositis, which is your anti-synthetase syndrome. So this antibody is nothing but anti-Jo1. So you can remember a mnemonic known as FAIR-MM. So you have fever, arthritis, ILD and Raynaud's. Pretty non-specific, no need to remember this also. And MM is muscle weakness. Alright, so FAIR-M actually is what you want to remember. And the antibody is anti-aminosyl tRNA synthetase or Jo1. So basically synthetase or Jo1. And this finding here is actually MM. The other finding is M for mechanic hands. Alright, so mechanic hands is what you see. So previously this was as dermatomyositis, now this is anti-synthetase syndrome. Alright, so this is about myopathies. Now talking about arthritis. So in arthritis, first of all, what would the aspirates show you? So this can also be asked to you. So normal appearance is going to be clear. In OA, which is non-inflammatory, will be clear. But in inflammatory and septic arthritis, you're going to have a turbid aspirate. Viscosity is going to be reduced in all of them. WBC count normally is less than 200. In OA, it has increased to 200 to 5,000. In inflammatory, you would have very high count of 5 to 50,000, whereas more than 50,000 count in septic arthritis would be seen, out of which polymorphs are less than 25% in non-inflammatory, 25 to 50% in inflammatory, and more than 50% in septic arthritis. Alright, so this is about the aspirates. Talking about two crystal arthropathies right here. So what you see here, whenever the first metatarsophalangeal joint is shown in a male patient, elderly male, alcoholic male, after an episode of binge drinking, as acute pain and redness of the great toe, this is your rat bite erosion. Large erosions with overhanging margins known as Martel G sign. The diagnosis becomes gout. On the other hand, when you don't have on the other hand, when you have knee joint which is being shown to you, and what you see is chondrocalcinosis. You can see how meniscus is calcified here. Chondrocalcinosis, this is a marker of pseudo gout. The most common joint to be affected by pseudo gout is knee joint. Okay, so what are the crystals? The investigation of choice is going to be aspiration, and you see the crystals. When you see under a polarizing microscope that there are these needle shaped negatively birefringent crystals, this is monosodium urate in gout. Whereas if you see rhomboid shaped crystals which are positively birefringent, this is going to be calcium pyrophosphate in pseudo gout. So calcium pyrophosphate deposition is also known as pseudo gout. Now quickly talking about pharma here. So gout management, remember in acute gout we have three options. First line drug of choice is always gonna be NSAIDs. So NSAIDs can be used here except aspirin and except paracetamol. Why not aspirin? Because aspirin also reduces the uric acid excretion. Aspirin reduces the uric acid excretion, and that can further lead to hyperuricemia, and not PCM, because PCM has very low anti-inflammatory properties. Alright, it is mainly used as antipyretic, as I am sure you all know. So these two drugs are not used. Apart from that, any NSAID can be used. Steroids can be used as intralesional or intraarticular injections, and colchicine actually is the most effective drug, but it is reserved for very refractory cases because of the side effect. It has very severe diarrhea. Alright, so colchicine is actually a microtubule inhibitor, and that is why, if you remember in biochemistry, I have taught you we use this in karyotyping for metaphase arrest, isn't it? So this is colchicine. It is technically most effective, but we don't use it because of GI effects, GI side effects. Alright, so this is acute gout. Chronic gout, the drug of choice, remember, is allopurinol. Very frequently asked question, allopurinol is not to be used in acute gout, only chronic gout. So the principle, allopurinol blocks the xanthine oxidase which breaks down the purine, so basically reducing uric acid excretion. So allopurinol and febuxostat block the xanthine oxidase. Very, very important mechanism that you want to remember. Allopurinol is also something that is used in Kala Azar in addition to hyperuricemia. Then we have one enzyme in birds which was converting uric acid into allantoin. So we thought, why don't we also use it? Birds are not developing gout, we should also not develop gout. So we came up with this uricase enzyme. So this uricase enzyme in the recombinant form is known as rasburicase or pegloticase. This question has also come a lot of times, alright. So these are the treatments that can be given for chronic gout. In addition, we can also increase the excretion of uric acid in chronic gout. So all of these drugs, probenecid, sulfenpyrazone, benzbromine and lesinuride can be used for increasing excretion. Alright, so metabolic drugs to reduce uric acid or to increase excretion are the management pillars of gout. Okay, very important. Talking about approach to diagnosis of arthritis. So in a chronic setting, you have to divide in the terms of inflammatory or non-inflammatory arthritis. So when you see that there is fever, raised ESR, CRP, morning stiffness is present, the pain increases on rest, or there is morning stiffness, that is how you are going to be diagnosing inflammatory, whereas pain which decreases on rest is going to be non-inflammatory arthritis. So within inflammatory, if I show you an X-ray like this which is showing you a lot of joint space reduction with a lot of erosions, particularly here at the metacarpophalangeal joint. We are talking about rheumatoid arthritis. So rheumatoid arthritis, remember rheum has 4 walls. So this is DR4. The most common joint is metacarpophalangeal joints. There is DIP sparing, distal interphalangeal sparing. There is joint space reduction, and the hallmark are marginal erosions. Alright. On the other hand, if DIP, PIP is most commonly involved, you have these marginal erosions with whiskering and periostitis. You can see this penicillin cup deformity. We are talking about psoriatic arthropathy. You can have telescoping and a destructive form known as arthritis mutilans. Obviously, you will have skin and nail changes as well. The most common joint to be affected is DIP. The most common form is oligoarthritis form. Already talked about it, no erosions but deformities. This is SLE-Jacquard's arthropathy. Alright, going on to non-inflammatory, the hallmark large joints are involved or in the hand. First carpometacarpal is the most common. Overall it is hip and knee. This is osteoarthritis. This is osteoarthritis. So you're gonna have this asymmetrical joint space reduction. You can see how the medial compartment is more common with sclerosis and cysts. You can have subcutaneous nodules. So remember DH and BP, the two things we know in first year, blood pressure and dissection, right? So you remember Heberden nodules are in the DIP, whereas Bouchard nodules are in the PIP. Okay. When you have a diabetic patient, the patient has this severe joint effusion of the foot, but the patient says he has no pain. He has no pain because of neuropathy. So this is a neuropathic joint or a Charcot joint in which you have 5 Ds. So disorganized, dense bones with complete destruction, debris and distension. Diabetes can also be given to you as history. So this looks bad, doesn't feel bad. You are shocked at the state of the destruction. The patient is pretty chill. So this is neuropathic or Charcot joint, and this is and the most common bones to be involved are the mid-tarsal joints. Okay, if you have a child with this widened intercondylar notch, this is hemophilic arthropathy. So this is hemophilic arthropathy because of collection of blood, hemarthrosis. You're having this. So in a child with squared patella or intercondylar notch, consider hemophilia. Boy would be given to you in the history because it is X-linked recessive, and you can also have pseudo tumors in the soft tissue which are muscle hematomas. Alright, so this is how you approach arthritis in a nutshell. Talking about spondyloarthropathy, so spine getting involved, one of the most important images. We've also talked about this in orthopedics and in radio. So what we are seeing here is ankylosing spondylitis. So they will give you the history that there is a young male in his 20s and 30s, remember HLA-B27, who has spine pain which increases on rest but reduces with activity. So this is inflammatory spine pain. In addition, they can give you there is bilateral heel pain which is because of enthesitis. Enthesitis means wherever there is tendon and ligaments getting inserted, you will have pain. They can also give you uveitis in this patient. Reduced spine flexion, reduced chest expansion can also be mentioned. So what is the investigation of choice is an MRI of the SI joints that will show you sacroiliitis. This is also the most sensitive finding. It is usually bilateral asymmetrical sacroiliitis. If it is unilateral sacroiliitis, always rule out tuberculosis. After that, it goes to the spine and there is complete fusion of the spine. You can see how the anterior posterior spine is fused. This is known as a bamboo spine. On an AP view, you can see that there are 3 fusions here. This is known as a tram track appearance, and this interspinous ossification is what is known as the dagger sign. Alright, so these are 3 signs that you have in ankylosing spondylitis. So all of this while I was talking about ankylosing spondylitis. I don't think I mentioned that. Okay, so this is angspond. What you want to contrast this ankylosing spondylitis with is DISH. DISH is diffuse idiopathic skeletal hyperostosis. So this is a disease seen in elderly. This is an AIMS question, and what you have is just along the ALL, anterior longitudinal ligament, you have this flowing ossification. So flowing ossification along the anterior longitudinal ligament is DISH. Alright, so DISH versus ankylosing spondylitis is what we wanna remember. Another important cause of spondyloarthropathy is something known as Retter's disease. So Retter's disease, remember, will follow either a GI infection or a sexually transmitted disease. It is a triad. So you want to remember, can't pee because urethritis, can't see because conjunctivitis, can't climb a tree because arthritis. So can't see, can't pee, can't climb a tree. 2 dermatological images can be given. So what you are seeing here is Circinate balanitis, and what you are seeing on the skin are keratoderma blenoragicum. So 2 very big names, but just hear them once. If they come in options, you'll be able to diagnose. So this is Retter's disease. Alright. Going ahead to rheumatoid arthritis. So already talked about the findings of arthritis per se, but the systemic findings are also very important. So this is one of the few connective tissue disorders where uveitis is not the most common ophthalmic manifestation, and it is keratoconjunctivitis. And it is scleritis that you want to remember. So scleritis, episcleritis and conjunctivitis, scleritis, episcleritis and keratoconjunctivitis sicca, very, very important. In fact, they've given you one question from Ophthal wherein they've shown you scleromalacia perforans, a bluish eye in a case of rheumatoid arthritis. Alright, so that is also one of the complications that can result. Apart from that, very important in the spine, you will have C-spine, you will have atlantoaxial dislocation, which is very, very specific for rheumatoid arthritis. You will have serositis, which is very common. So in the lung and heart, most common actually is pleuritis and pericarditis. You can have renal, you can have skin manifestations. So rheumatoid nodules are actually the most common extra arthritis. In fact, rheumatoid nodules are the most common extra articular manifestations. You can also have Felty's syndrome, which is important. So in Felty's syndrome, you will have neutropenia, RA and splenomegaly. So neutropenia, splenomegaly, rheumatoid arthritis is Felty's syndrome. Also remember here you have Kaplan syndrome. So I'm sure you know this. Kaplan syndrome is pneumoconiosis with rheumatoid arthritis. Okay, so these 2 syndromes also you can keep in mind. Talking about treatment. So drug of choice for RA, as you know, is methotrexate, but in pregnancy contraindicated. So remember, in pregnancy methotrexate and leflunomide are contraindicated. The drug of choice in pregnancy is going to be hydroxychloroquine. And also remember that in pregnancy, usually the RA flares reduce, alright, it reduces in pregnancy. So this is about drug of choice in pregnancy, HCQ. Talking about biologicals, they love to ask this, alright. So we memorize this very long list of biologicals, but usually it is this which gets you questions out of all monoclonal antibodies. Very, very, very important, okay. So in pharma, I'm going to teach you the other monoclonal antibodies as well, but I'm not going to be teaching you these, alright. So you do this right here, right now. So we have all of these TNF alpha inhibitors. So you remember ACE inhibitor ko maro goli. So you remember goli ACE inhibitors. Alright, so you have adalimumab, certolizumab, infliximab, golimumab. These are all your monoclonal antibodies against TNF-alpha, whereas etanercept is your fusion protein. As the name says, it is a fusion protein between TNF-alpha and the IgG-Fc, the same thing against which we had rheumatoid factor. So this is a fusion protein between both of these is what you want to remember. So these are all your TNF-alpha inhibitors, ACE inhibitors, GOLI is what you want to remember. Then what is your IL-1 receptor antagonist? It is anakinra. So A1 is what you want to remember. IL-6 inhibitor with COVID, I'm sure all of you remember tocilizumab. This was repeat AIMS question. So tocilizumab is IL-6 and Sari Dunya wanted tocilizumab. So you remember sarilumab. So sarilumab and tocilizumab are IL-6 inhibitors. So you remember toci and saridunya. B cell depleter or CD20 inhibitor, I'm sure you already know this. This is rituximab. Then CTLA4 inhibitor is abatacept, very important. So this is abatacept, co-stimulation is the CTLA4 marker as we've done in immunology, and small molecular JAK inhibitors are tofa and baricitinib. Alright, so this list you definitely want to go through one more time. Keep this in your choti copy, go through this once. This has the highest chance out of all of the new drugs to be asked. Okay, then we talk about vasculitis, the final topic of rheumat. Very important. One question is always going to come from vasculitis. So first of all, a few one-liners wherein Harrison and Robbins don't agree at all. So most common in adults according to Harrison is idiopathic cutaneous vasculitis, whereas according to Robbins it is giant cell arteritis or temporal arteritis. So I'm leaving it up to you. Nobody asked these most common questions, but just for your reference, most common in children all over the world is Hinoch-Schönlein, but in Asians it is said to be Kawasaki's disease. Remember, Kawasaki is anti-endothelial cell. Kawasaki is anti-endothelial cell antibodies. I'm not covering Kawasaki's again because I've already done this with microbiology, alright. So this is about vasculitis. Then coming to the pathophysiology, this is where you get a bunch of questions from. So where you have granulomas or type 4 hypersensitivity is going to be giant cell or temporal arteritis, Takayasu's arteritis, which are your which are your large vessel vasculitis. You'll also have granulomas in GPA, that is granulomatosis with polyangiitis, previously known as Wegener's, and eosinophilic granulomatosis with polyangiitis, previously known as Churg-Strauss. So all of these have granulomas. Coming to ANCA, you have C ANCA, which is positive in Wegener's or GPA like we have already discussed, and P ANCA is positive in the other two, so microscopic polyangiitis and Churg-Strauss or EGPA. Remember all three of them are known as renopulmonary syndromes, wherein you have involvement of glomerulonephritis and pulmonary hemorrhage in all three of them, which is Wegener's, MPA and Churg-Strauss, most importantly MPA and Wegener's. Then we have immune complex deposition. So in immune complex, you want to remember HSPC as the mnemonic. Out of HSPC, H is HSP, Hinoch-Schönlein purpura, S is SLE-induced vasculitis, P is PAN, very important, polyarteritis nodosa, and C is cryoglobulinemia, which is associated with hepatitis C. So remember, cryoglobulinemia, C for hep C, whereas PAN is P, you can make as B, hepatitis B. Alright, so this is the most important HSPC, immune complex mediated vasculitis. Alright, so this is about pathophysiology. Very underrated. People tend to ignore this and focus on the classification, that is your Chapel Hill, but this is where you get questions. Alright, so focus here first. Now talking about Chapel Hill classification, so we have two large vessel vasculitis, which is giant cell and Takayasu. Then we have two medium vessels, which is thromboangiitis obliterans and PAN, and we have also Kawasaki's, which we have already discussed, and then we have small vessel vasculitis that we'll discuss. So first things first, most common one in elderly, giant cell or temporal arteritis. So what you're going to have is an elderly patient more than 50 years with jaw claudication, which is the most specific symptom here. What you will see on this image is a VVG stain, von Verhoef-Jessen, which is an elastic stain which shows you this degradation. You also see this cord-like thickening of the superficial temporal artery, which is the most common artery to be involved in giant cell arteritis. The next step would be to start steroids. Start steroids immediately because there is impending risk of AION, blindness by the involvement of ophthalmic artery. You don't want that. While you send the patient for biopsy, which is the gold standard, you don't want patient to lose vision. So first you start steroids, then you send for biopsy, and because there are skip lesions, you want to do a biopsy more than 1 centimeter at least. Okay, so this is giant cell. On the other hand, if it's a young female and you see the aortic arch getting involved, arch vessels getting involved, this is the most common in Asians. This is Takayasu arteritis or aortic arch syndrome. The most common artery to be involved is the left subclavian artery. This is a DSA image which is showing you this narrowing of the left subclavian artery. This can present as a BP difference between the two upper limbs, a very characteristic finding. And whenever you see this, you know, one bell of clinician should go in your mind and consider various DDs. So one thing you want to consider is preductal coarctation of aorta. You want to consider aortic dissection if it's an emergency, and you also want to consider Williams syndrome, which has supravalvular AS, supravalvular aortic stenosis can also lead to this. Alright, so it's a very nice pattern about different BP in the two limbs. Apart from that, because it's large vessel, it can block renal artery, coronary arteries, resulting in hypertension and MI as well. Alright, so we have a modified Sharma's criteria that we use for Takayasu. The most common vessel is left subclavian. Very typical history, a young smoker with very severe limb pain. The diagnosis is thromboangiitis obliterans, or also known as Berger's disease. So this is Berger's disease, remember, not Berger's with just an E, but Berger's disease, or as I had written earlier, thromboangiitis obliterans. Okay, so smoker, very typical. The vessels which are involved are your limb vessels. So you're gonna have most commonly the radial and the tibial arteries getting affected, and you would see on DSA that there are these corkscrew collaterals. Okay, so there are gonna be this corkscrew collaterals that you're gonna be seeing. On a biopsy, you will see micro abscess. See this vessel completely blocked with these abscesses. So neutrophilic micro abscess is what you would see. In this disease, you will have arteries, veins and nerves which are getting involved, and that is why the severe pain, but lymphatics are not involved. Okay. Next, you want to talk about PAN, polyarteritis nodosa, very important image. This image is showing you fibrinoid necrosis. So remember, you're going to be seeing fibrinoid necrosis in PAN. Hepatitis B, very important, and you can also see hypertension because of renal artery getting involved. What is not involved is pulmonary artery. So PAN, PA, no, pulmonary artery is not involved. Glomeruli are not involved, obviously, because it is small vessel. Alright, so this is very important. Talking about the next disease, when you see that there is this saddle nose, upper respiratory tract is involved, you have cavitatory lung lesions in this HRCT. So when you have a triad of upper respiratory tract, lower respiratory tract and kidneys showing you RPGN, crescentric rapidly progressive glomerulonephritis with hematuria, you want to consider Wegener's, right? So this is Wegener's or granulomatosis with polyangiitis. C and K is the antibody. In a child with these purpura with no thrombocytopenia. So this is non-thrombocytopenic purpura, and the criteria says purpura plus any of these. So you can have abdominal pain, arthralgia, IgA-induced nephritis or leucoclastic vasculitis. So this is HSP, or now said as IgA-mediated vasculitis. Okay, so very, very important. This always gets you one or the other question. Remember, this can also predispose to intussusception. So they can also make a radio correlation question here with intussusception. Finally, a disease that can involve any artery, large, medium, small. This, as I'm visible you, this is a triad of oral ulcers or genital ulcers and uveitis that you are seeing here. So I am talking about Behçet's disease. So Behçet's, remember, has antibodies against alpha enolase. HLA-B51 is predisposed here, and on biopsy you see neutrophilic vasculitis. Okay, so neutrophilic vasculitis is what you see. You can see a hypopyon in the eye, you can see these ulcers in the oral and genital tract, and you also see this test which is known as the Pathergy test. Okay, so whenever you inject anything, even if you inject saline, this is going to have this inflammatory reaction. So this is all you got to know about Behçet's. So this marks the end of a rapid fire revision of rheumat. I hope this will be useful to you. Expect at least 1 or 2 questions from this topic. Very short topic, very cute topic in my opinion. I hope this is useful. Thank you so much.